Uh, Hello, friends. Welcome to um, part three and the last part of how to optimize ultrasound images. Uh, I've shared part one, I've shared part two. This is the last part. And the last part, in my second video, I stopped at looking at measurements and I said we must take measurements in the three dimensions. If 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 this is our organ here, then we are supposed to take, we give sagittal view, we're supposed to take length and height, then we are supposed to get a transverse view and take the width. That gives us the volume. Modern day measurement, many of the physician and societies of medicine prefer volume, because volume gives us the entire picture. Because sometimes someone may have a longer organ, but maybe it is short in the other dimension. So volume gives us that awesome composite, and it's easy to compare volume compared to comparing a certain dimension like length. So that is that. And then the other point that we can talk about that is important for us to give when we are making out those images to our physician, to our radiologists, to our doctors, is color flow. As a sonographer, we are supposed to look at anatomy and physiology of organs or of structures. Now, the other stationary images, grayscale images, or black and white, like you call them, may give us the anatomy, may give us the surface smoothness, may give us the dimensions, may give us the cogenicity. But we need to look at also at the pathology. We need to look at perfusion, because we expect that the different organs are supplied with specific arteries, and we expect that they are drained with specific veins. So it is very important that we put color flow, or we put color Doppler for every organ to confirm perfusion. I've seen so many times where people have done abdominal ultrasound scan and they say the abdominal ultrasound is very normal, minus putting any Doppler application to confirm flow. What if you're saying the liver is, when it is happening a part of figo flow? I mean, blood is no longer moving towards the liver, but moving away from the liver due to pathology in the liver or something like that. So we really need to look at that and see very well that actually an organ is normal when it is normal. I mean, I've scanned the patients where you put color flow on one of the kidneys and is no longer getting blood supply due to a certain pathology. And by you just recognizing that, calls for other investigation of the kidney to see what could be causing that. Now, this is not a detailed Doppler study of maybe the renal blood vessel or not, but you're supposed to confirm flow or no flow to different organs. Because blood vessels are some of the structures we are supposed to look at when we are doing these various ultrasound scans of the different regions. But what we're scanning, for example, the abdomen, we are supposed to look at the aorta, because the aorta is one of the structures in the abdomen, and we are supposed to talk about it. So when you're looking at these organs, make sure you put color Doppler to confirm presence or absence of flow. Hepatic veins, portal veins, common bile duct. How do you confirm this is a common bile duct but not hepatic artery? The simple tool may be Doppler. So for every organ that we scan in the body, we must give a shot or one sonograph or one image that is showing blood flow to that organ, to help whoever is interpreting or whoever is going to review those images confirm flow or no flow. Then, second last point for optimization of ultrasound images are labeling or talking sonogram. I've seen quite a number of sono papers where, I mean, it is a liver, we see liver. But where are you? Me, I'm just looking at a sonogram. The liver is big. What view of the liver are you giving me? So the simple rule for any labeling, you're supposed to give us the organ that you're scanning, the view in which you're getting that organ, and then the position where you are. For example, left, the organ is liver, sagittal, left lobe, that is the position. Liver, sagittal, left lobe. Or left lobe of liver, that is the organ, sagittal, and then you tell us lateral, or you tell us left lobe with caudate lobe, or left lobe with IVC. If it is transverse, you tell us left lobe liver, transverse, then you tell us superior. Such that if I'm reading and then you say me left lobe liver, transverse, superior, I know where you are. So even if there is pathology and I'm writing a report or I'm interpreting for the patient, because sonographers, by law, we are not supposed to interpret to the patient, apart from in sub-obstetric cases where we show them the heart, maybe the gender, depending on the country where you are and the medical laws in that, whatever. But sometimes the doctors interpret. But the doctors need to have a look at our images. Some doctors actually don't just look at the report or the radiologist report, but they go ahead to look at the images and follow the report with the images. So by you giving them those positions, you're showing them where you are. Right kidney, sagittal, mid. Right kidney, sagittal, lateral. Right kidney, sagittal, medial. Right kidney, transverse, superior. Right kidney, transverse, mid. Right kidney, transverse, inferior. So the guy knows. Spleen, sagittal. Spleen, transverse. Because the spleen has two views, either sagittal or transverse. But also put color flow at the splenic ileum to show blood vessels entering and leaving. Ekyo no kigenda tuyamba to win confidence in our physician, in our radiologists. Essaawa tuyinza okuba tuli lucky nti we are just producing akafaananyi kamu oba bubiri, but trust me, soon bagenda kuba batusaba to either have a CD showing all the organs you've captured, and they should be talking organ images. So when you put on those labels, uterus, sagittal, mid, uterus, sagittal, right, uterus, sagittal, left, uterus, transverse, inferior, uterus, transverse, mid, uterus, transverse, fundus, or superior, cervix, sagittal, cervix, transverse, urinary bladder, sagittal mid, urinary bladder, sagittal right, urinary bladder, sagittal left, urinary bladder, transverse superior, urinary bladder, transverse mid, urinary bladder, transverse inferior, urinary bladder, uretrojets. I mean, someone knows what you're talking about and where you are. Those are talking. Common femoral vein, right common femoral vein, right common femoral vein with compression, right common femoral vein with argumentation, something like that. Someone knows what you're doing and where you are, so they can follow. When you say pathology here, they can look at your images and actually see pathology. So they are going to buy your report because you're exactly communicating. And these are small things that we do every day in our department, or some of us we don't do, but we know how to do them. Because definitely when you leave the boundaries of where you are and try to go somewhere else to look for work, that is the standard you expect. And to some people, that has been the stumbling block. And then lastly, when we are documenting pathology or any cyst or any mass or any something, you're supposed to document pathology in 3 views. You're supposed to document that pathology you're supposed to document that pathology in sagittal view. You can put dual screen, you put sagittal and the transverse. The same mass, give us in sagittal and then transverse. And then in the sagittal view, measure the length and height of the mass. Then in transverse, give us the width. And then also remember to label where you're seeing them. If the liver is in, if the mass is in the right kidney, maybe you say right kidney sagittal, then you give us that sagittal view of the mass, then you say transverse. In the transverse view of the mass, you remember to give us the organ, right kidney, transverse, then you give us that. And then the third, you can unfreeze one of those images on the dual screen and then put the same position. For example, if it is sagittal, put sagittal one side and sagittal another side, and then put color flow. Color flow is the only thing that confirms to whoever is reading your report that you're talking about a cyst or a mass that has flow uptake or blood supply. In fact, one radiologist asked me, brought my image and asked me, is this a cyst? And I said, yeah, it is a cyst. And said, prove that before me it is a cyst. And we're talking about images that I had captured some time back. Of course, I could not prove. The only way that I could have proved that is if I'd put color flow and there was no flow. So don't make the mistakes that I made. Learn from me that anything that confirms a cystic collection is by color flow. I've even worked with a radiologist who wanted me to, if I'm doing obstetrics and I want to document blood of the fetus, to put color flow to confirm it is a bladder, fetal bladder. So those are things that we can use to document any pathology. I want to thank you for watching. I want to thank you for loving me. Please share, please comment, and send this to another person that you think it may help. Share it with your friends, share it with your colleagues in the profession. And lastly, to our dear patients that are watching this, please always follow instructions of the sonographers, because the instruction help to make our work easy. Oba kyanguyiza omulimu gwaffe okukolako obulungi. Buli instructions zetukuwa ziba n'omugaso okulaba ng'ofuna scan results ennungi. Mwebale kunjagala, mwebale kungoberera. May God bless you. Mr. Selfcare, UG.